Are you a mental health practice owner juggling the complexities of running your practice? Meet Admira, a CRM and operations software solution designed to simplify your day-to-day workflows and streamline your operations. Admira makes managing your practice easier by simplifying referral management, client onboarding and communication, and other essential tasks. With customizable workflows, email templates, and automation tools, Admira helps you run your group practice more efficiently. Plus, it integrates seamlessly with your email platform, website, and EHR system, bringing everything together in one place to save you time and reduce errors. Ready to transform the way you work? Visit admira.com to learn more. That's ADMIRRA.com to learn more. You can sign up for a free 30-day trial or schedule your free demo today. Admira.com. This is the Practice of the Practice podcast with Joe Sanok, session number 1195. Welcome to the Practice of the Practice podcast. I am Joe Sanok, your host, and we are here 3 or 4 times a week helping you build a thriving private practice you absolutely love. We have been digging into all sorts of issues, both clinical and business, throughout this year, and today is going to be a great day. We have Dr. Harvey Max Chochinov with us, who is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at Cancer Care Manitoba Research Institute. His research in palliative care has resulted in more than 350 career publications, broaching diverse topics such as depression, quality of life, suicide, vulnerability, spirituality, and existential distress. He's also led a large program of research on dignity within the healthcare setting, which includes the development and study of dignity therapy. He's the co-founder of the Canadian Virtual Hospice, co-editor of the Handbook of Psychiatry and Palliative Medicine from Oxford University Press, and his latest book is entitled Dignity in Care, The Human Side of Medicine, published by Oxford University Press. He's an officer in the Order of Canada and an inductee into the Canadian Medical Hall of Fame. I am so excited to have you on the show today, Harvey.
Thanks, Joe.
Yeah, well, we're talking about dignity in care. Now, is this something that kind of throughout your career has been a focus, or was that something that you kind of discovered along the way?
It certainly wasn't there at the outset. At the outset, being a psychiatrist, I was interested in the early parts of my career looking at things that were more kind of typically quote unquote psychiatric. So, we studied things like depression, desire for death, will to live, anxiety, hopelessness. But at a certain point in time, in exploring what I would refer to as kind of this experiential landscape of end of life care, we discovered that there were things that were um, pressing, but yet in some ways kind of ephemeral in terms of their influence on patient experience. And that's when we started to enter into the area of dignity. And the clue that that was important was looking at the Benelux countries. The experience reported by Dutch physicians is that the most frequent reason why patients had sought assistance with hastening death was because of a lost sense of dignity. Now that goes back like 30 years or plus 30 years. Um, but at the time, there was no empirical work on dignity. And we said, well, if dignity is worth dying for, dignity is worth studying. And so we embarked on a large program of research, following that particular path.
Hmm. Now, just so we're all on the same page with terminology, how do you define dignity when it comes to working with clients and patients?
Well, the question really kind of addresses, why the research was important in the first place. People define dignity in a whole variety of ways. The dictionary definition of dignity is the idea of being deserved of honor, respect, or esteem. Um, we started to explore it by sitting down with patients who were near the end of life to find out what it meant, when it worked, when it didn't work. And I guess two critical things that came out of that from the quantitative studies, what we reported is that the single most ardent predictor of sense of dignity in a large cohort of dying patients was this idea of how they perceive themselves to be seen. In other words, and for me, that was actually rather an epiphany. In other words, what it means is that patients, at least metaphorically, even though this is driven by empirical data, metaphorically are looking in the eye of the healthcare provider for an image or a reflection that will affirm their sense of self, their sense of personhood. So that's the first piece of my answer. The next piece of my answer really, again, goes back to qualitative data that we got from patients. And there we published an empirical model of dignity in the terminally ill. And what that model shows is the various different sources of distress that can affect someone's sense of dignity. So, and they, as you would expect, can include physical dimensions of experience in the throes of a life limiting condition. It could include external things to the individual, so things like social support and privacy concerns. And then the most kind of nuanced thing that we reported within that model is something that we call the dignity conserving repertoire, which really is about the spiritual, the psychological wiring of that individual. So things like hope and feelings of meaningful roles and spirituality. So, and it's not a hierarchical model, which means that for different people, different elements from within that model will influence their sense of dignity. So at the end of the day, when you're sitting down with a patient, you need to find out from them what are the things that are most profound in shaping their experience.
Mm. Now, I know sometimes in research, the research is kind of naming what's already there and saying, okay, we haven't really classified this, but this is what we're observing. And then other times the research is kind of pushing the envelope forward and saying, these are emerging models that maybe we haven't named as much. When you think about kind of dignity therapy, first, I guess, do you agree with that? You can always disagree with me. If you would add something to kind of how research is conducted in your mind. But if those models are where you would say we would land, where does dignity therapy kind of fall in regards to emerging ways of doing therapy versus kind of naming things that maybe were part of the human experience already?
So, I mean, what I would say is this. Intuitively, we have a sense of what dignity might mean. But the problem is with intuition is that, it may or may not be kind of, borne out based on experience with patients. When we produce the model, and again, this is based on input of patients who are nearing end of life, as you point out, many of the things in that model are things that you would predict would have an influence on sense of dignity. So things like pain, for example, good symptom management, good social support, all of those things you would say, well, I might have predicted that those would have some influence on sense of dignity. But what also happened is that there were some things that appeared in that model that we might not have previously expected. And one of the things that came out, and this is a segue to responding to your comment about dignity therapy, one of the things that came out of our model was the idea that for patients, generativity turned out to be an important issue. And by generativity, I mean that for some patients, assault on dignity is the sense that who they are will not have some ripple effect beyond this life. In other words, this idea of, so what did it all amount to? What did life mean? What was the meaning of my having been here? And so that led us to develop a therapeutic innovation that we have coined dignity therapy, which is now the most studied psychological intervention in palliative care. There are, over 100 papers collectively in the medical literature and about 12 systematic reviews. And dignity therapy is a way of, with the help of a trained therapist, guiding a patient towards creating a legacy or a generativity document. So this is a conversation that we train therapists to elicit from patients with life-threatening, life-limiting conditions. Those conversations are recorded, transcribed, edited, and then returned to the patient so that they can share it with the people in their lives who matter.
Mm. Now, what kind of shifts has this led to in regards to how psychiatrists, therapists, other medical professionals are maybe approaching end of life or other conversations or treatment within dignity?
Well, I would say, I mean, the effect, hopefully, that it's had and hopefully continues to have, and one can only hope that that effect will grow, is a heightened sensitivity to the importance of these things when it comes to patient care. Um, in other words, I mean, much of what we are trained to do with patients is very much in the realm of the transactional. The thing we do to the patient. We give people drugs, we do surgery, we radiate. So we perform various different tasks or interventions, and those transactional tasks we begin to think of as being in their totality what medicine has to offer. What my work hopefully has done, and the work of others, of course, in this particular lane, is to say that there are other facets of medical care that aren't within the realm of the transactional, but really within the realm of the relational. And to operate in that lane, you need to understand something about personhood. You need to understand not only what the person has, but who that individual is. And so I'm beginning to see that kind of mentality, uh, certainly in palliative care, being seen as, part and parcel of holistic, comprehensive palliative care, maybe in some ways kind of operationalizing the kind of work that Dame Cicely Saunders suggested palliative care ought to embrace at the outset when she founded the modern hospice movement and said, "You matter because you are you." Well, it turns out, I mean, you matter because you are you, not only because of the ailment that you have that brings you to medical attention, but you matter because you are you based on who you are as an individual. So much of my work certainly over the last decade has really been focusing on this whole notion of personhood and really alerting healthcare providers about the importance of eliciting personhood if you're going to be providing person-centered care.
Mm. Listen, I didn't take insurance in my counseling practice because I had no idea how to handle it. The process of accepting insurance outside of a group practice can be tough, but most people looking for mental health care want to use their benefits to pay for sessions. If you're like me and you feel a little scared about taking insurance or you just want to make it easier on yourself and you're interested in seeing clients through insurance, Alma can help. They make it easy to get credentialed with major insurance plans at enhanced reimbursement rates. They also handle all the paperwork from eligibility checks to claim submission and guaranteed payment within 2 weeks. Plus, when you join Alma, you'll get access to time-saving tools for intake, scheduling, treatment plans, progress notes, and more in their included platform. It's going to make it so much easier for your team, so you can spend less time on administrative work and more time offering great care to your clients. Visit helloalma.com/Joe. That's helloalma.com/Joe to get started. I think that, just as we think about the things that we all learned in graduate school and then the development of different approaches, sometimes it's easy to miss, this emerging research or emerging best practices. Um, what for you are people that are staying at the cutting edge of this? What are they doing regularly to help stay clinically relevant in regards to as they're thinking about these issues? And maybe even if you want to dig into just some of what this therapy and this modality looks like practically, would love to hear kind of what that looks like practically as well.
Well, I mean, the details of dignity therapy are, kind of like out there, certainly available in the literature and available online. I mean, the description of it in sort of a thumbnail sketch is that, patients are engaged in this brief conversation, um, and are asked about things, and there's a kind of a framework of questions that we have that elicits, core issues around personhood, and particularly things that they would want known, that they would want remembered. So some facets of it are biographical, the particular vignettes from your life that you feel were formative or that you would want known or remembered. And some of them are more kind of emotionally evocative and have to do with things that you've learned, things that you would want remembered or known, lessons you would want to convey, specific wishes or hopes that you might have for individuals that you are about to leave behind. So that conversation is organic. Again, we trained therapists and have done so for decades now from around the world to be able to elicit those conversations and to know how to take those transcriptions and to make them into a legacy document that can then be given to that individual to share with their loved ones. And those documents, can have multi-generational effects. But I think even more broadly, I mean, the practice of dignity and care is not something that is just for, selected patients who feel that they need to do something about generativity. Dignity and care is really an approach for all healthcare providers to understand that to be a healthcare provider means more than being a human body mechanic. It means being a healer. And to embrace that role means to be attentive, not just to the physical, but to the psychosocial, the spiritual, the existential. And to do that at a minimum, one needs to ask, and we've done studies on what we call the patient dignity question. What do we need to know about you as a person in order to take the best care of you possible? We know that can be the stem of a brief conversation, and we have had these conversations with hundreds, and now there are thousands of patients who have participated in studies that have taken place around the world. And what is we've shown in our results is that this enhances a sense of connectedness, a feeling of being respected, of being heard. And for healthcare providers, it even increases job satisfaction and therefore perhaps may mitigate against sort of this stance of becoming very kind of robotic and disengaged from the human pathos of what's happening in a clinical encounter, and therefore may be something that actually prevents burnout.
Mm. Yeah, I think that's fascinating to see, kind of how it's being implemented and kind of how people are enacting it. Uh, for your own personal habits, for me, I always love when there's researchers and experts that have studied something deeply. I think it's impossible for it not to affect our lives personally. For you personally, like, how do you live differently because of the research you've discovered, or how do you think differently about the world, or are there habits that you do quarterly or weekly or annually that impact you because of this research that you've done?
Hmm. That's a hard question. I mean, I feel like the research in some ways has affirmed things that hopefully at some point in my life I would have discovered, and I think with age we all eventually do discover, and that is that we are all vulnerable. That all of us encounter issues in our life that can be overwhelming, and that to my mind, is kind of not so much a reflection of personal weakness. It is a reflection of the human condition. That vulnerability is really kind of woven into the DNA of the human experience, and so I think that I carry that with me and see people through a lens that understands that. The other thing that I think that I've learned, and I've actually written about this over the last few years, something that I call the platinum rule. Intuitively, when we are trying to determine, I mean, what might be in the best interest of someone, what treatment might they need? What's the best approach in this situation? Or even interpersonally, like, so what do I think this person, might need from me at this time? The intuition is the golden rule to say, we use ourselves as a gauge or as a barometer for what that person might need. And what I've come to realize is that as important as that approach is, as kind of giving us a starting point, the fact is that it still means that we are imposing this external standard on what somebody else might be feeling or thinking or needing. And so the platinum rule, which I've written about, really says doing unto patients as they would want done unto themselves. In other words, being mindful that all of us bring a particular perspective that is shaped by the way that we were raised, the society in which we were born. And that is going to create certain biases or taint our outlook in ways that may be discordant with the patient's lived experience. And so that is another, I think, lesson that I've learned along the way that I've been writing about, and hopefully I would think would be an important element of the whole dialogue that we have certainly in this country about EDI, equity, diversity, inclusiveness. I think to be mindful of that, first and foremost, we need to be aware that our own lens, our own gaze, is shaped in ways that we may not even be aware of. So we need to, I think, heighten our alertness to the fact that we are seeing things uh, in a way that is shaped by the fact that we have a particular outlook. But the important outlook, of course, is for the patient. And the way this makes certainly, I mean, it makes has implications in a whole variety of ways. But certainly, one very practical way in palliative care, where sometimes you can no longer elicit what the patient might want, the correct question to the son or daughter or spouse who's sitting at the bedside of their now uncommunicative loved one is not, what would you like us to do? But if we could bring your person back into this room the way they were a week ago or a month ago, what is it that they would want? And I would say that is a platinum standard, and that is raising the bar on person-centered care.
Mm. Yeah, I love that idea of looking back a couple months and thinking through, what would that have looked like if we had had some of these conversations, or if they were thinking through it with them. The last question I always ask, and I swear these interviews have gone by so quickly, but the final question I always ask is, if every private practitioner in the world were listening right now, what would you want them to know?
Um, well, I mean, two thoughts come to mind. One is the title of an article that I published years ago, and the title of that article is "The Secret Is Out. Patients are people with feelings that matter." So that's the first thing I would like people to think about. And maybe the last thing, just given the limitations of time, I was asked to give a speech to our incoming medical students this year, their white coat ceremony. And amongst the many other things that I said to them was this: patients won't care what you know until they know that you care.
So important. Harvey, if people want to follow your work, if they want to learn more about what you're studying and what you're researching, where should we send them?
Dignityandcare.ca, or they can follow me on Twitter at HM or
Awesome.
LinkedIn, Harvey Max Chochinov.
And we will link to all of that in the show notes also. Harvey, thank you so much for being on the Practice of the Practice podcast.
Thanks, Joe. My pleasure.
Well, take some action as you listen to this show, as you look back. We had our Future of series, And before that, we also had our Better Brains series. So all sorts of really interesting discussions then. We talked about the future of trust. We talked about how veterans can recover from moral injury. We talked about trauma and polyvagal theory, and what it takes to actually make change that matters. So all sorts of really interesting shows we've done in the last month or so. So go back, check out some of those shows. Also, we couldn't do this show without our sponsors. Thank you so much to Alma for being our sponsor today. You know, I wish Alma had been around when I had my private practice. I had no idea what I was doing. That's why I didn't take insurance. But if Alma had been there, I would have. And there's no reason that as a clinician, you should be spending hours on paperwork to bill for insurance, or not knowing for sure that you'll get reimbursed for sessions with your clients. If you're interested in seeing clients through insurance, but don't want to navigate the process and paperwork on your own, Alma can help. They make it easy to get credentialed with major insurance plans at enhanced reimbursement rates and a guaranteed payment within 2 weeks. Visit helloalma.com/Joe. That's hello, ALMA.com/Joe to get started. Thank you so much for letting me into your ears and into your brain. Have a great day. I'll talk to you soon. Special thanks to the band Silence is Sexy for that intro music, and this podcast is designed to provide accurate and authoritative information in regard to the subject matter covered. It is given with the understanding that neither the host, the producers, the publishers, or guests are rendering legal, accounting, clinical, or other professional information. If you want a professional, you should find one.